कदीर पहले से एक बार प्रेजेंटेशन स्टार्टिंग पॉइंट एक बार देख लो।
Sir, am I audible? Good morning, sir.
Hello. Morning. Yeah, you're audible. Can you just start the presentation from the first slide? Can you share it from the first slide? And just check if the slides are moving.
Good morning, sir.
Your slides are not moving, Kadir. Wait for it. Can you just reshare the presentation? Hello. Rahul? Kadir? Kadir? Kadir, can you hear me? Kadir, we can start. Kadir? Srinivas, can you hear me?
Hello.
Yeah, please start. Please start.
నాకు వినపడతలేదు. అవునా, 1
Huh?
second. I'll just check. Okay.
Please start, Kadir. एक बार लॉग ऑफ करके लॉग इन करो फिर से।
Good morning, sir. Good morning, everyone. Am I audible, sir?
Yes. Yes, 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 audible.
Please go on, Sadir.
Sir, am I not audible, sir?
You are audible. Please go on.
I can continue speaking.
Sadir, please go on.
Can you hear us now? You start.
అనిల్ ఒక్క నిమిషం స్టార్ట్ చేస్తున్నా వినిపిస్తుందా? ఓకే. Sir, I'm starting, sir. Okay, sir. Good morning, everyone. Today, topic for my presentation will be nutrition in ICU. So, as we all know, that nutrition is the area where everybody is slightly least concerned, or it's a least priority of interest for everyone when they are starting or thinking a patient who is critically ill, where we have to wait for the patient to get better and then to start a nutrition. So in this aspects, we need to know what and how to start in feeds for a patient who is critically ill to improve his overall outcome and increase his or decrease his ICU stay or decrease his ventilator-free days. So in this picture, we can see a patient who is sick. He is already been into bones where improper feedings, not meeting his calorie requirements, can lead to severe malnourishment. So it's not that when we should start thinking when to start, it is has how to start and how early to start. So malnutrition is one of the most common problems which we face among the ICU patients. The impact is more on the morbidity and mortality of the patient. Traditionally, nutritional support in critically ill patient was regarded as adjunctive support to provide the fuel to patient during the stress. But I feel this is one of the most important contributory factors for the overall improvement and clinical outcome or betterment of the patient. Now, there is vast areas of research in the development of nutrition, providing nutrition on patients who are critically ill. We can see in this picture clearly a patient who was got initially admitted with normal body, as per his body mass index and all, he is well built and moderate, well nourished. But as he is being in the ICU on a ventilator with multiple supports and all, his lean mass has totally gone down and he has become bones again. So to avoid this, we should know when to start nutrition and how far the providing adequate nutrition to the patient will be important in his overall outcome of the patient. So we can see as per the data, the prevalence of malnutrition in US hospitals is around 30 to 50%. In European hospitals, it is around 37%. Canada, it is 31%. Moderately malnourished patients will be around 21% and severely malnourished will be 10%. Latin America and all, it is coming around, the prevalence is around 39 to 62%. So we need to know what is the malnutrition prevalence in our ICUs. As per the data, what they have been published in the recent guidelines is the Indian ICUs have a malnourishment rate between somewhere between 40 to 80%. So it's pretty high, wherein because of the pressure from other consultants and all, thinking that feeding might affect the outcome of the patient. Patients who are having GI surgeries and all, where most of the surgeons will feel if we start early nutrition or providing enteral feeds or any feeds to them can cause leaks from the anastomotic sites and all. So that concept of not providing feeds has to be properly conveyed, and uh, evidence-based what exactly the outcomes will be beneficial to the patients have to be clearly explained to the other consultants also, to avoid the prevalence of malnutrition in our ICUs. What are the consequences? As I said, because of the decreased not providing adequate nutrition to the patient, there will be reduced GI function. The mucosal barrier will be altered. Absorption and immune functions of the GI system will be lost. There will be decreased kidney function, decrease in the GFR. There will be altered from pharmacokinetics of the drugs because of the protein binding. If the patients are malnourished, they can have hypoproteinemia, hypoalbuminemia, slow wound healing, decreased immunity, and overall increased morbidity or mortality and length of the ICU stay, which indirectly acts to the cost of the patients. How do we provide a nutrition support? We need to have a proper screening tool and assessment of the nutritional status when the patient comes to an ICU. What is the diagnosis? How is it? Is he malnourished, malnourished, or moderately or severely malnourished? How do we plan nutrition for that patient? Is it enteral or parenteral nutrition? All those things have to be considered while thinking or planning for a patient. How to prescribe? What is the dose? What is the calorie intake? Which preparations are you going to give? Whether it's elemental, semi-elemental, or polymeric feeds and all, which I'll be discussing in my coming slides. How do you implement those nutritional strategies? Proper clinical nutritionist who will be helping us to guide what type of a feed is important, how to implement it, when to start, when to stop. Proper suggestions from a dietitian or clinical nutrition is more important. And at the same time, whether our patient is getting adequate nutrition and all, it has to be properly monitored, and again reevaluation. And we need to see about the complications, side effects, and other problems which are associated with nutrition. I'll be discussing in the next slides. As I told, prevalence of malnutrition is very high from admission to discharge in ICU patients. Up to 62% of the patients suffer from malnutrition at the time of admission, and up to 78% of patients shows a decline in their nutritional status during the overall hospital stay of the patient. In the Aspen guidelines published in the clinical nutrition in the ICU, they showed every critically ill patient staying for more than 48 hours in the ICU should be considered at risk of malnutrition. There's a strong consensus, and the malnutrition, as I said, it leads to overall morbidity and mortality increased, and increase in the hospital stay, and at the end indirectly costing high bills on the patients. How they are malnourished? We know many of the patients, when they are planned for any procedure and all, they will be kept NPO, and they'll be missing meals for investigations, stress of surgery and therapeutic procedures, hospital environment. The food which we are providing may not be appetizing if the patients are awake. They may not like the food, inadequate intake, maybe intolerance of the feed itself can be one of the factors contributing to the malnourishment. Surgery, trauma, and all dysphagias and psychological stress to the patient can itself add to the malnourishment. Assessment and risk stratification of patients for malnutrition is the first step towards achieving a personalized nutrition care for all the critically ill patients. I said, as a patient comes to ICU, unless we have a plan or a goal to achieve what is his nutritional status and how we can achieve his adequate nutritional calories, is the most important and most care for the benefit and outcome of the patients. We had different assessment tools as SGA, Subjective Global Assessment, which have A, B, and C, which considers into a checklist of things based on the history, based on the previous weight loss, dietary intake, what he used to take, gastrointestinal symptoms, functional capacity, disease which he is having, and in relation to the nutritional requirements, physical, like how loss of subcutaneous fat, we'll assess whether the patient have some mild loss, moderate, or a severe loss of the muscle wastings, ankle edema or sacral edema, and all, and we give a rating. So A is well nourished, B is moderately or suspected to be malnourished, and C is severely malnourished. The other is nutritional risk screening score, wherein also considers three things: score based on the severity of the disease, score based on the nutritional status, and score based on the age. This will help in assessing the screen. It acts as screen tool and helps the nutritional to know the nutritional status of the patient in the ICU. Is a Nutric score, wherein we have variables to see the factors, the parameters which we take into consideration are age, Apache score, Apache 2, SOFA, number of comorbids, and days from the hospital to ICU admission, and IL-6. If we don't have IL-6, we also can consider the 5 parameters, and based on that scoring, it is between 0 to 10. 0 to 5 is low score, and 6 to 10 if you are taking IL-6. It is associated with worse clinical outcomes between the mortality and increase in the ventilator days. And if we are not taking IL-6 into consideration, we consider 5 to 9 is the highest score. And again, if it is between 5 to 9, it's a high score in associated with worse outcomes of the patient. How to decide and how to start a feed, we'll be taking the topic into these things: when to feed, how much to feed, what will be the dose, what type of feed you want to give, whether it's enteral, parenteral, or both, what will be the contraindications of each, advantages and disadvantages, cost, does it add to the cost burden to the patient, and what are the other nutrition requirements, the micronutrients, macronutrients, immunonutrition. That is also one of the major factors we have to look into it. As I said, first is the assessment tools, then know what are the who are the at-risk patients to develop malnutrition in the ICU. That's a GLIM criteria. It is a two-step model for assessing screening and diagnostic assessment. It takes 5 criteria. 3 are phenotypic criteria and 2 are the etiological criteria. So diagnosis of malnutrition requires at least 1 phenotype and 1 etiological criteria. Risk screening, one is a diagnostic assessment like phenotypic. It includes weight loss, non-volitional weight loss, low BMI, reduced muscle mass. Etiological criteria like reduced food intake or assimilation, and decreased disease burden, which is more disease burden and all inflammatory conditions. If these at least 1 phenotypic criteria, 1 etiological criteria is made, and it means that the patient is at high risk of malnutrition. Again, you have to determine the severity of malnutrition based on the phenotypic criteria. The other methods are DEXA scan, MRI, and ultrasound scan for assessment of muscle mass. It is with a good reliability, non-invasive, economical, and it doesn't require any special equipments and all. Bedside trained trained residents can do ultrasounds bedside and assess the muscle mass, and also we can know gastrointestinal scan where we can see the motility in the muscle thickness, intestinal muscle wall thickness, and the motility also can be seen, and they can know which patients are more prone for gastrointestinal intolerance. As I said, the psoas muscle is one of the easy tool ultrasound where we'll be able to use, we'll be able to measure the thickness and to assess the nutrition, whether they are malnourished, where they comes into mild severity, moderate or severely malnourishment. CT scan also can be used where they say they'll do at a level of L3 vertebra and they see the mean Hounsfield units of this psoas muscle, wherein again at stages from day 2 and then at stages like day 7, day 14, they'll assess and they'll do the thickness of the psoas muscle. But only thing it is shifting the sick patients for CT imaging will be difficult. Hence, we more rely on the ultrasound imaging, wherein we will be able to see the muscle density and all. Critical illness, as I said, they are in a catabolic state, which malnourished patient demonstrate a systemic inflammatory response with complications like increased infections, MODS, prolonged hospitalization, and hypoalbuminemia. How can we prevent, like what will be the advantage of providing nutrition in these patients? They decrease the metabolic stress response, they preserve the lean body mass, prevents the oxidative injury, reduces the disease severity, and decreases the length of hospital and ICU stay. And overall favorable patient outcomes will be seen if we have a major role in providing proper and adequate nutrition. I'll talk about what is adequate nutrition also in the next slides. As I told, bedside examination is more important to assess our clinical nutritional status of the patient, where we can see the muscle thickness. We can have tests like indirect calorimetry and volume status, weight loss, obesity, all these things we can see. We can also assess whether the nutrition is getting lost from the PEG side or PN. If you are administering parenteral nutrition from the line side, it is draining, or it is like drains like fistulas and all from where the food is getting drained out. We should know all those things. Important bedside assessment to know whether is there any other confounding factors which add to the malnourishment of the patient. In providing adequate nutrition, as I said, to the patients, we may face a lot of challenges where if the patient is having decreased gut motility because of the high dose of sedation which we provide in the ICU patients who are ventilated, there are high chances if there is a decreased gut motility, the patient may have aspiration, increased GRV, gastric residual volume, which can cause pooling and regurgitation that can cause aspiration in those patients. Patients who are in respiratory failure requiring long-term BiPAP or CPAP therapy, where they will be not able to provide NIV breaks. In that situations, we will not be able to meet the calorie requirements, even if we have placed a NG tube or providing NG feeding can cause aspiration risk. Patients who are requiring steroids, they can have other complications like hyperglycemia, hyperphagia, and also electrolyte disturbances. And the other problem is during the procedure, most of the time we see patients are kept NPO depending on the surgery, whatever they are planned for, and depending on the availability of the surgeon or the availability of operation theater, they will be kept for a longer time NPO, wherein again, during that period of time, the patient will have decreased calorie requirement, calorie supplementation that duration. I said, what are the complications of like if we feed? What else we can have issues with the feeding also? If the patient is kept NPO for a longer time and we start feeding, the patient may develop a refeeding syndrome, wherein refeeding is nothing but there will be because of feeding, there will be electrolyte disturbance because of the secretion of insulin that cause the intracellular movement of the electrolytes, causing hypophosphatemia, hypokalemia, and hypomagnesemia that can itself cause various electrolyte disturbances, can cause various cardiac abnormalities and other issues with the patients. Rhythm disturbances in the patients. Fluid imbalances, overhydration, giving IV fluids more, or if the patients are on hypertonic, like dehydration, all that can cause severe fluid shifts. Hyper and hyponatremias, electrolyte disturbances are the more common patients who are on nutritional supplementations or those who are giving only fluids. Blood sugar abnormalities, as I said, based on the disease conditions of the patient, whether the patient may go into hyper or hypoglycemias. Uh, Small mineral abnormalities when vitamin abnormalities because of the fat soluble vitamin deficiency, vitamin K can occur because of the lack of feed, proper nutritional feeds which are being administered to the patient. Micronutrient deficiency like thiamine and zinc deficiencies. Metabolic and respiratory complications which can cause like hypercapnia because of the increase in the carbohydrate intake of the patients. How do we follow a feeding protocol in these patients? As I said, as per the SPEN guidelines, if the patients have been not started on the enteral feeds in the first 48 hours, they are more prone for malnutrition. So if there is no contraindication to start off in feeds, we should start within first 48 hours of feeding. Starting in with a slow rate and assign, we should look for the signs of any GI dysfunction, look for gastric feeding intolerance like gastroparesis, large gastroresidual volume, abdominal distension, or elevated IUP. If there's no such features, then we can slowly increase on the enteral. Reassess every point of time, reassess, and then try to meet the calorie requirements. If the patient is having intolerance to the enteral feeding, what we can do? We temporarily stop the feeds. We start providing prokinetics to the patient. Most importantly, as per the many studies, they have showed that erythromycin acts as a very good prokinetic, and even metoclopramide can be used. We can also think if the patient is not tolerating feeds properly, post-pyloric feeding should be considered in those patients. And again, I told every point of time, we have to reassess whether the proper feeding, whatever we are administering to the patient, there is tolerance or not. If there is an intolerance, then we need to think of other routes of administration, providing prokinetics, giving laxatives if they're not opening bowel and all that has to be considered. And few patients, we need to rule out the triggers which can cause GI intolerance, like can be infections and all that has to be also considered. As I told, we should not, what is the optimum requirement of the feeds? It's not the exact adequate calorie requirement or the normal requirement of the calories from the day one. So usually from day one, we start slowly progressing the nutritional intake of the patient. We don't overfeed the patient. Again, I'll be discussing what are the drawbacks or the side effects, which the disadvantages which we get when the patients are overfed also. So initially in this graph which is showing from days, and the percentage of goal which we have achieved in the nutrition. So over a period of 6 to 7 days or 8 to 9 days, at least we should achieve almost 70 to 80% of our nutritional requirement. So initially it has to start with 20 to 40% and slowly go looking at other complications. Like as I told, refeeding syndrome is one of the things. If the patients are not properly fed, if the patient is not properly fed, then we should wait and then start feed slowly and gradually we should escalate it. Okay. So as per the guidelines, if oral intake is not possible within 48 hours in critically ill patients, adults should be performed initiated rather than delaying enteral nutrition. If oral intake is not possible, early enteral nutrition should be started within the first 48 hours. This is a strong grade B recommendation. Gastric access should be used as standard approach to initiate enteral nutrition. It is again a grade of recommendation, strong consensus. In patient with gastric feeding intolerance, not solved with prokinetic agents, as I told, we should think of stop those gastric feeding and go for post-pyloric feeding. These are all the ESPEN guidelines. In patients deemed to be at high risk for aspiration, post-pyloric mealy jejunal feeding can be performed. It is a strong consensus agreement. As I told, early enteral nutrition improves the clinical outcome of the patient, decrease the length of the stay. The main important is it prevents the intestinal villus atrophy, gut atrophy, and minimizes the translocation of the organisms, like bacterial organisms or GI tract in the bloodstream that prevents. It improves the feeding tolerance. If we make the patient NPO for a longer time and then start feeds, there will be definitely gastric intolerance will be there, because there will be a lot of gut translocation of the microorganisms, and there can also, because of the increased activation of the inflammatory cytokines and all, that can cause internal intoleration. How the advantages will be, if we make early nutrition, it decreases, as I told, decrease the incidence of infection. It provides immunity, prevents translocation of organisms from the gut. That self can prevent infections. It decreases the catabolic state, and it increases the enterocyte apoptosis, prevent dysbiosis. As I told, autophagy is one of the most important also factors. If the patients, as I told, we should not overfeed the patients. If the patients are overfed, as per the EPANIC trial, as we have seen, if the patients are overfed, the autophagy is a process wherein our body takes up the abnormal organisms and all, which can be like fought, or the immunity which can be done with these things will be lost, and the patient will not be able to, the outcomes of the patients will not be better. Patients who are hemodynamically unstable, again the challenges which I said, and have a functioning gastrointestinal tract should be fed early. Hemodynamically stable patients should be fed early within first 24 hours by appropriate using amount of feed. Choice of feeding, again depending on the tolerance of the patient and patient preference also. This is a graph showing from the study which was published in the NEGM article, which they have seen the outcome of the patient survival between the late feeding versus early feeding. Early feeding and days of intubation were more when compared to the late feeding. The outcome of the patients were less at the 28th day. Indication of feeds, as I told, NG feeds. If the patient is having some oral head and neck surgery wherein they are not able to take oral intake, we have to start with NG feeds. Patients who are on intubated ventilator state, inadequate intake, because of nausea, vomitings and all, we should start off with the NG feeds. Patients who are unconscious patients, and the patients who are requiring NIV for a longer time, or patients who are having dysphagia, they should be considered for starting off NG feeds. Different types of enteral feeds are polymeric feeds, oligomeric feeds. Polymeric feeds are commercial prepared formulas, as we all know, which we use in the ICU, and blenderized or kitchen feeds. Oligomeric feeds will be elemental, semi-elemental, or peptide based. Specialized disease-specific nutritional strategies are present to provide adequate needs based on the patient conditions, like diabetes patient, cancer patients, patients who are having kidney diseases, patients who are sick, critically ill patients. The major part of our chunk of feed will be like proteins, carbohydrates, and fats, which have been broken down into different polymeric, oligomeric, and elemental feeds. Polymeric are complex forms with intact macronutrients, especially proteins. Oligomeric and monomeric are semi-digested, semi-elemental feeds. Fully digested elementals are like rich carbohydrates and all. Use a standard polymeric feed when initiating enteral nutrition in the ICU setting. We suggest avoid the routine use of all specialty formulas in critically ill patients in surgical and medical ICUs. As I told, appropriate selection of enteral formula is more required based on the patient condition, high caloric requirement, and fluid restriction. Select a more fluid restricted, energy dense formulas feeds. Surgical or trauma patient, we consider using immunomodulating formulas. That persistent patients who are having diarrhea, we should feed them with mixed fiber containing formulas. In patients who are suspected with malabsorption, considering small peptide based formulas. In patients who are having CKD patients, they are like electrolyte disturbances and all. We have to use electrolyte rich formulas. If none of these, consider the standard formulas. These are the from the SPEN guidelines. How to administer feeds? As I told, it should be a closed, ready-to-use system. Where ready-to-hang closed system, large volume bags, we can have a hang time of 24 to 48 hours. It reduces the chances of infection risk, and we cannot add modular components. I told carbohydrates, proteins, and fats cannot directly be added. It reduces the nursing time and it increases the efficiency of the supplementation of nutrition to the patients. In smaller volume bags, the hang time is 8 hours. There are chances of increased infection risk, and we can add modular components to this one, but the disadvantages will be increased nursing time and there can also be a delay in administration of the feeds. Powdered formulas requiring preparation, hang time should not be more than 4 hours. There is increased chances of infection, needs to be prepared in special formula rooms, not in a separately, requires a sterile water, increased nursing time, again adding cost to the patient. As I told, proper hand hygiene should be used, proper tube placement. We should identify the patient based on what patient we are giving, administering what feed. Proper labeling should be there. Head and elevation should be done. We should see at a regular intervals the patient is able to tolerate or not. And again, different between administration of feeds, we can have different concepts in feeding. There few people follow continuous feeding and few they give intermittent feedings. There are different advantages and disadvantages for both. Continuous feeding, there will be a tolerability, there decrease in frequency of distension, diarrhea will be less GRV, better control of delivery of feeding, nursing care will be easier, a better metabolic management with constant infusions. Glycemic control will be better because of less fluctuation in the glucose levels, in the insulin levels. Less gastroesophageal reflex because it will be a continuous feed through pumps, wherein it will be going at a rate of whatever based on the calorie requirement. We administer 30 to 40 ml per hour, so GRV will be less, and the patient will have a better absorption of the nutrients and also less gastroesophageal reflex. As I told again, it was published. GI intolerance monitoring enteral intolerance was published in SPEN guidelines. GI intolerance is usually defined by vomiting, abdominal distension, complaints of discomfort, high GRV, reduced passage of flatus and stool, or abnormal abdominal radiographs. In critically ill patient with gastric feeding intolerance, intravenous, as I told, erythromycin is mostly considered. Hypocaloric nutrition, less than 70% of the energy requirement in the early phase of acute illness, has to be considered and can be increased slowly up to 80 to 100%. In patients who do not tolerate full enteral feed during the first week in the ICU, the safety and benefits of initiating a parenteral nutrition should be weighted based on the case base. It cannot be a blanket, a single formula for everybody. So based on the case to case, we should decide whether to initiate a parenteral nutrition for the patient or not. Contraindications for enteral nutrition, patients having uncontrolled shock, severe hypoxemia and metabolic acidosis, upper GI bleed, and GRV. As I told, we regularly should not check for the GRV, but if the patient is having more than 500 ml of aspirates in 6 hours, or bloating or regurgitation, then we should think of stopping the enteral feeds. And when the patient is hemodynamically unstable and we are feeding through enteral route, we should also consider the risk of bowel ischemia and all. Abdominal compartment syndrome again is one of the contributory factors wherein we should not start contraindication where we should not start enteral feeds. And in patients who are having high output fistulas without distal feeding access, GRV between 200 and 5 ml can be considered increased, and more than 500 ml is a cutoff for discontinuation of enteral nutrition in patients who are having high output fistulas. Risk of aspiration will be high. Patients for more than 70 years, the risk of aspiration will again go so high. Neurological impairment, patient who are in ARDS, patients who are being prone, there are risk of aspirations. And use of bolus feeds, again, the risk of aspiration goes up high. As I told, patients will be on medications, antibiotics and all. There can be with enteral nutrition, there can be risk of diarrhea associated, infections, malnutrition, and multi-organ failure itself is one of the factor for causing diarrhea in patients. As I told, various parameters are used to assess the GI dysfunction, clinical parameters, radiological parameters. Clinical parameters, as we all know, vomitings, abdominal distension, and all that has to be considered. Abdominal compartment syndrome. Radiological parameters, like where we can see through an X-ray, abdominal dilated bowel loops can be seen. Air under the diaphragm, if there is a perforation and all, that is to be considered. Radiological diagnosis, radiologic parameters which we can see is, I told, gastrointestinal motility scoring system is there, where we see the intestinal motility, where we see the intestinal wall thickness, and based on that, we assess the patient's GI intolerance. Biochemical parameters like lactates, CRP, albumin, indirect marker for our nutritional status. Again, that cannot be considered because it's a negative phase reactant. It can go low even in patients who are in infections. General biomarkers like endotoxins, which are released by gram-negative organisms in intra-abdominal sepsis. Measurement of endotoxin levels can help in assessment of the sepsis. Ultrasonography, as I told, GUTS protocol, which we see gastrointestinal diameter, mucosal thickness, peristalsis, and also the blood flow of the bowel, which can be considered, which can be visualized in ultrasonography. Decreased or increased GI peristalsis can be noted. Intestinal peristalsis, along with it, if there is a decreased blood flow, that can again guides towards gut ischemia in patients who are hemodynamically unstable. That has to be done bedside, and it is one of the thesis for our resident who is being doing here. So we have been found that patients who are mechanically ventilated and who are having GI intolerance, these have been a good correlation between ultrasonographic findings and the patients who are having clinical parameters which shows vomiting symptoms. What is the cause for the dysmotility in patients who are sick? As I told, many factors will be considered: dyselectrolytemias, narcotics, medications those who are on, and sepsis itself decreases the gastrointestinal motility, ischemia, ventilator dependencies, more fluid overload that can cause, and gut microbial dysbiosis. As I said, if we don't feed the patients early, there will be alteration of the gut mucosa, alteration of the gut microbia, that itself can cause GI dysmotility. These are the things which I already discussed. In enteral nutrition, as I told, if the patient is hemodynamically unstable and requiring high vasopressor support, and if the patient's MAP is less than 50, so we should stop temporarily, look for the signs of GI intolerance, because the patients are prone to look for the GI vascularity based on the ultrasound, and they're more prone for gut ischemia, and we should stop feeds for temporarily, and we should wait. And then if the patient's clinical condition or it becomes hemodynamically stable, then we should slowly initiate on the feeds. As I told, how to start the feeds and is also more important, how much feed to be given. It depends on multiple factors depending on the stress. Burns patient, trauma patient, the energy requirements will be a little higher. Estimation of energy requirements is based on the two formulas which standardly we use, like Harris-Benedict equation, which is like standard thing which we regularly follow. And one more is Ayrton-Jones energy expenditure, which is two different formulas for spontaneously breathing patients and ventilator dependent patients. ACCP guidelines suggest to at least provide 25 kilocalories per gram of the usual body weight. So it is actually 25 to 30. In case where the patient is having in stressful conditions, the calorie requirement goes up higher. To how and what type of feed we should give, again, I told which type of feed to be decided, and then how to administer. Mode of feeds administration was more important. Whether enteral versus parenteral, all guidelines are in favor of enteral nutrition to prevent the gut. First thing, because of the multiple factors, it maintains the GI tract integrity, it preserves the gut microbia, and also decreases the cost burden on the patient, and also the complications associated with the parenteral nutrition can be avoided if we start as early enteral feeds as possible. When we compare enteral versus parenteral, there is no like head-to-head benefit of the parenteral nutrition. There's no mortality benefit, no difference in the number of ventilation days, no difference in the hospital length of stay. Significant reduction in the infectious complications is like with enteral nutrition is there, and definitely cost saving. So in all the ways, unless the patient have clear-cut contraindication for enteral feeds, we should not think of going into parenteral feeds because of the major risk complications which I discussed just now. Enteral nutrition, as I told, based on the guidelines, we have to initiate if there is no contraindication within 48 hours. Generally accepted guidelines are 24 to 48 hours of admission. We should initiate enteral nutrition. Different routes based on the clinical condition and the severity of the disease of the patient. We should decide what route of feeding we should administer to the patient. Formula comparisons, as I told, different formulas are made. Blenderized are the home or kitchen feeds or the commercial formulas which are there. Each one have its own advantages and disadvantages. Kitchen feeds, as we all know, we do not know what is the nutritional content. We don't know the osmolality. They may contain lactose and all, poor microbial quality, and there are very high chances of infections. And because of the high viscosity, they can have GI intolerance. Commercial formulas, they are balanced nutrition. They have a proper nutritional content and calorie mentioned on the proper feed. They have low to moderate osmolarity, so tolerance becomes better. They are lactose and gluten free. They are sterile, and when we administer through a NG or NJ tube, they can have proper flow. But because of the high viscosity of these feeds, like blenderized foods and all, they can have obstruction, they can have intolerance and all. Dosing, I said, we have multiple factors which will be helpful in deciding how much is the dose and how much is the percentage of the calorie requirement has to be done in the first days of the ICU admission, and slowly how gradually will improve the calorie intake of the patient based on the disease conditions. Complication, as I told, all those things which has been discussed. Parental nutrition, in cases where there is a clear-cut indication where you cannot initiate enteral feed, then we cannot keep the patient unfed or we cannot make him nutritionally depleted. And there are high chances the patient goes into a malnutrition. In those situations, definitely we should have thinking to start off a parental nutrition. Through a peripheral or a central line, we have two different preparations. Through a peripheral preparation is there, TPN, and also a central venous preparation is there. The components of parental nutrition are dextrose, lipid emulsions, amino acid, electrolytes, vitamins, and minerals. As I told, these are the things where non-functional inaccessible GI tract, complete bowel obstruction, short bowel syndromes, intestinal failures, and in patients who are having high output intracutaneous fistulas. And if a patient is expected to undergo a major GI surgery and if enteral nutrition is not feasible, then PN should be initiated within 5 to 7 days preoperatively if the patient is malnourished. Dextrose, depending on the calorie requirement, 3.4 calories per gram, 10 to 70% of the concentration of dextrose will be given. Infusion rate should not be exceeded more than 5 mg per kg per minute. Higher doses are associated with hepatic steatosis and other complications. Proteins and amino acids, 4 kilocalories per gram, 3.5 to 10% of the concentration. Dose is again 0.6 grams per kg to 2.5 grams based on the clinical condition of the patient. We also have specialized amino acid solutions available, which can be used as in TPN formulas. Lipids, 10% emulsions are available, 20% emulsions are available. Recommended dose is 1 gram of fat per kg per day. Conventional emulsions like soybean or safflower oil-based products are available. Current recommendation is to use olive-based, as data says the olive-based emulsions may be associated with a reduction in ICU length of the stay and duration of mechanical ventilation. But many studies have to be completed on it. It is still in pipeline. Glutamine, as I told, parental nutrition is prescribed to critically ill patients. So parental supplementation of micronutrients is also more important. Glutamine is a strongly recommended thing. The dose is 0.2 to 0.57 per gram per kg per day. It reduces the mortality in clinically ill patients, reduces the infections complications, and decreases the length of the hospital stay. The other parental nutrient compositions includes electrolytes, minerals, vitamins, immunomodulating agents like glutamine, omega-3 fatty acids, antioxidants, zinc, micronutrients, vitamin A, C, and E. There are again the complications associated with parental nutrition, as I said, while inserting a line or central line and all, there can be a complication like pneumothorax. If you injure a thoracic duct, the patient can land up in chylothorax, air embolisms, lipid, like also we have fat embolism seen in patients who are having administered with parental nutrition. Infectious complications, because improper handling of the central line again can lead to infectious complications, like the more patients who are sick and on a PN for a longer time, they can have candidemia also. Hepatobiliary complications like fatty liver, cholecystitis, and refeeding syndrome is also there. Macronutrients and micronutrients also becomes an important part of our nutrition administration. We have gold standard many methods to assess the energy expenditure of the patient. As I told, the simplest formula what we regularly follow is 25 to 30 kilocalories per kg per day as per the Harris-Benedict equation. If the patient are sick in trauma, we increase up to 30 to 35. CLD patients, we go up to 40 kilocalories per kg per day. Cancer patients for non-ambulatory, we can again consider 25 to 30. In nutritional weight gain, patients who are on weight gain nutritional depletion, 30 to 35 kilocalories per kg per day. Hypermetabolic or stress patients, 35 kilocalories per kg per day. Ideal for weight is BMI is 18.5 to 24.9. Adjusted body weight, BMI is 30 kgs per meter square. Actual body weight minus ideal body weight in 0.33 plus ideal. This is a formula. Actual body weight is a weight measured just before the hospitalization. Okay, but when we are administering feed and all, when the patient is there in a longer duration for the ICU, we should consider the predicted body weight. Proteins, as we all know, the protein requirement is more important in patients to prevent the ICU acquired weakness. Catabolic response is very high, 1 kg of loss of muscle per day over for the first 10 days of ICU and can lead to ICU acquired weakness. Critically ill patients, the requirement as per the ASEAN guidelines is 1.2 to 2 grams per kg per day. In patients who are having acute kidney injury, the protein requirement considered is 1.2 to 1.7. In traumatic brain injury, it is 1.5 grams to 2.5 grams per kg per day. CLD patient, it is again 1.2 to 1.5. CKD patients, we decrease the protein intake 0.8 to 0.6 gram per kg per day. And those who are on dialysis, again, the requirement is different. We can go higher of protein intake. And the patients who are on CRT, the requirement again goes up high, it is 2.5 grams per kg per day. And burns patient, it is 1.5 to 2 grams per kg per day. This is all taken from the ASPEN and ASPEN guidelines 2019. Micronutrients, as I said, patients who are already in a malnourished or a critically ill patient, they are very high risk of deficiency of micronutrients. That increases the length of the hospital stay. Those patients who are micronutriently deficient decreases the immunity, decreases the overall wound healing in these patients. Parenteral route, intravenous route, or IM route may be indicate where absorption. Parenteral route, intravenous is more preferred. Where absorption is poor or for rapid correction of deficiency, we cannot administer IM route. Micronutrient, as I told, reduced intake, increased utilization, increased impaired absorptive capacity for the specific nutrients, and different nutrient interactions. These can lead to micronutrient deficiencies in the patient. At risk of refeeding syndrome, the patients who are not fed for a longer time, those who are malnourished, prolonged NPO, cancer patients, and all, they are at high risk of refeeding syndrome. To consider this, we should check electrolytes regularly, administer patients multivitamins and all, and electrolyte administration correction should be done at regular basis. Multiple sources for recommendation for preventing refeeding syndrome has been published by the NICE guidelines, ASPEN and MACLE guidelines. We should first identify the patients. Electrolyte replacement and monitoring should be done at regularly. A phosphate drop of 30% should be managed by reduction of enteral feed. If the patient has landed up in refeeding syndrome, we should decrease the intake initially and gradually go up. Start at low and go slowly up to 5 to 20 kilocalories per kg per day. It should be done in a stepwise fashion based on the monitoring all the parameters of the patient. Immunonutrients in burns more than 20% body surface area, glutamine 0.3 to 0.5 grams per kg per day should be given for 10 to 15 days as soon as the enteral nutrition is commenced. In critically ill patients, 0.2 to 0.3 gram per kg per day for the 5 days with enteral nutrition. Complicated wound healing, a longer period should be administered for 10 to 15 days. Immunomodulating formulas not to be used routinely in patients unless the patient in patients who are having severe sepsis and all, we should avoid using immunomodulating formulas. Omega-3 fatty acid, eicosapentaecoisonic acid, and decahexaisonic acid from fish oil. It decreases the inflammatory response by decreasing production of inflammatory mediators. As I told, omega-3 fatty acids can be useful in preventing these inflammatory cytokines. They decrease the inflammatory cytokines and decrease the inflammation. Few omega-6 fatty acids, they increase the process of inflammation. So omega-3 fatty acid is useful in prevention of the inflammatory response. We have a study published in Critical Care Medicine Journal 2006, effects of enteral feeding with eicosapentaenoic acid and gamma-linolenic acid and antioxidant in mechanically ventilated patients. They have seen that the patients who are administered with these omega fatty acids and all, they have a decreased ventilator-free days and decreased length of hospital stay. This is also one of the data showing compared with the placebo and eicosapentaenoic acid. This is a baseline. As we started with the eicosapentaenoic acid and omega fatty acids, there is a decrease in the oxygen requirement, and also the oxygen ventilator free days is high in patients who are being treated with omega fatty acids. So there have been a role, and we also have seen this role of administration of omega fatty acids in our COVID patients. So in patients with severe sepsis or septic shock requiring mechanical ventilation, tolerating enteral nutrition, a diet enriched with omega fatty acids and elevated antioxidants contributed to better ICU and hospital outcomes and was associated with lower mortality rates. This was again an article published in JAMA, which showed omega fatty acids have better outcome in patients with acute lung injury. Actually, the ventilator-free days or the clinical outcome in patients. Conclusion, what they said was initially the previous study which showed improvement outcome, but JAMA in this article they showed twice daily enteral supplementation of omega-3 fatty acid and oxidant did not improve the primary endpoint of ventilator-free days. The other, again, micronutrient arginine, wherein arginine, as we have seen in inflammatory response, they release nitric oxide that can cause vasodilation and all. If there is a patient having deficiency of arginine, so the pathway, this pathway will be decreased and the inflammatory mediatory pathway will be in continuation. So we will have less arginine available. So if we supplement arginine, so arginase will be activated, and in patients to improve healing and all, they act on these enzymes, arginase, they act on proline, and they increase in the collagen formation and hence prevent inflammatory response. Antioxidant nutrient combined with vitamin and trace element have shown to be associated with reduction in the mortality in critically ill patient and reduction in the ventilator-free days. Rationale for these antioxidants is like as we all know, antioxidants decrease the oxygen-free radicals. Balancing these by administration of antioxidants will help in improve the organ function, immune function, and mucosal barrier of those patients. Fluids, as we all know, the fluid requirement in the ICU, if we increase in the fluid requirements are there, again, the patient may have decrease in fluid overload, and they can cause uh, like fluid overload cases can decrease, they can cause overall increase in the mortality and morbidity by fluid overload, decrease in the absorption, intra-abdominal pressure can go up high. So maintenance fluid concept is not to be considered, and they can impair with the hamper. There will be increase in the gastrointestinal, like what we say, mucosal edema will be there, and again, they can decrease the intestinal absorption of the nutrients and all. So avoiding fluid overload should be considered. And also in patients who are being fed NJ, fluid, they can have electrolyte disturbance like hypernatremia and all. Regular fluid flushing should be administered, but it should not cause over bloating the patient with fluids. Fibers and prebiotics, they stimulate the growth of normal gut microbiota, so they are useful. Use of soluble fibers should be considered in all ICU patients to help maintain the commensal microbiota. Probiotics, routine use of probiotics in the ICU is not considered because, again, they can be a double-edged sword. They can be a translocation of this probiotic organism, can again cause worsening of the clinical infection of the patients. As I told, depending on the requirements, whether what to feed, isocaloric is like normal caloric feeding is an energy administration of patient defining the target. What is the achieving as per the calorie assessment? Initially, as I told, we should go up. What is optimum requirement is nothing but initially start up with up to 30 to 40% of the calorie requirement and go up to normal 82%, 80 to 70 to 80% at the end of 7 to 8 days of the patient. Hypocaloric in patients where we are thinking of refeeding syndrome and all, we should go with a slow to prevent refeeding syndrome and slowly escalate in a stepwise manner. Hypercaloric feeding, again, that is deleterious. If we are meeting more than 110% of the requirement of the feeds, the patient may have insulin resistance, hyperglycemia, hepatic steatosis, prolonged mechanical ventilation, and increased mortality. In patients who are hemodynamically unstable and requiring high vasopressor support, as I said, initially stop the feed for some time to prevent the gut ischemia, slowly increase trophic feeding up to a 20 ml per hour. We should start. It is just to preserve the intestinal epithelium, and it helps in secretion of the enzymes from the brush borders that can enhance the immune function of the patient. Overnutrition can cause, it is again I said, it is deleterious. It can cause infection, hyperglycemia, hypertriglyceridemias, hypoxias, increased liver function, increased LFTs because of the steatosis. There can be hyperbilirubinemia, hypercapnia because of increased carbohydrate content. There can be difficulty in weaning off ventilator, and also the patients may have metabolic acidemia. Undernutrition, again, the risk of infection goes up high, surgical complications, impaired wound healing, increased length of the ICU stay, muscle atrophy, muscle weakness, ICU acquired weakness is one of the complications of undernutrition. I be coming to an end. These are the major landmark trials which have been published. E-panic trial, there is a cumulative evidence indicating the provision of full energy target administration nutrition to requirement of full estimated energy expenditure is harmful rather than the beneficial, independent of the route of delivery, whether you administer through enteral route or a parenteral route. If you administer high calorie feeds or a full energy expenditure in the first days, there will be a harmful outcome. Calories trial and a Nutria-2 trial, these are the major RCTs published several years ago, showed no difference in the mortality when enteral nutrition and parenteral nutrition are used in similar doses. So there are no advantages of enteral over parenteral nutrition. However, the later RCT suggests a possible harm for full enteral nutrition in patients with shock when compared to full PN. So if the patient is severely shocked and all, and there are high chance of risk of malnutrition because of prolonged ICU stay, at least the parenteral nutrition can be considered. Nutria-3 trial, the most recent RCT in mechanically ventilated patients receiving vasopressors, confirmed the hypothesis that early full nutrition by any route is not beneficial, but it is rather harmful. Effort trial, it's a protein-related trial, high-dose protein versus a standard 1.2 gram per kg per day, started within 96 hours of ICU admission and continued up to 28 days in mechanically ventilated patients. The results showed no difference in time to discharge alive from hospital, but possible harm from high protein in patients with baseline, patients who are having acute kidney injury, and patients who are severely ill. This is the graph showing wherein early full energy, comparing early full energy feeding versus like underfeeding or trophic feeding in patients who are severely ill, and in a patient with stepwise going in patients with daily progression of feed. As I said, early full energy requirement associated with increased mortality, more infections, more GI complications, and there is no difference in the outcome by all the studies which have been done. France, Nutria-3 trial, Eden trial, and Arabic also has done in the intact trial. Then what should we do? See, what should we do is avoid early full feeding by any route because of the signal of harm or no benefit. Avoid high protein in the early period. Monitor for refeeding and overfeeding by regular monitoring of electrolytes and all. Monitoring for GI complications to look for regularly feeding intolerance and all. What we can do, what could be done, is start early enteral nutrition with low dose and increase progressively. Small or no benefit of early enteral versus early PN. Delayed enteral nutrition, it depends on dose dependent how the patient is required. Individualize after 3 to 5 days based on the illness trajectory. There is, I said, there is no single blanket rule. We should individualize patient based on the case-to-case basis. The main rationale what we need to understand is their patient should not be prolongedly underfed. Okay. What we are unsure of, what is the optimal time still to start, how to slowly progress, and how to individualize the treatment, that all based on the enteric feed intolerance. Take-home message, malnutrition is very much prevalent, but timely nutritional intervention as a therapeutic benefit, it helps in improving the patient clinical outcome. Medical, we should consider nutrition as a treatment. and it remains a challenge for starting a nutrition in patients. Early nutrition is always a good way to go. Ensure it is delivered appropriately. Consider PN when definitely it is not possible to administer enteral route in high-risk patients. So summary, integral nutrition should be considered as an integral part of the critical care. Nutritional support teams are there where clinical dietitians and all are helpful for optimizing our nutritional support in patients. Nutrition therapy should be tailored based on the patient-to-patient requirement. We should never forget that patients should be fed as they cannot be starved, which improves their overall outcome of the patient. If we starve them, the length of the stay, ventilator-free days, everything is going to go up. Thank you, sir.
Well, Shyam.
Thank you, Kadir, for taking through the various aspects of nutrition in the critically ill patients. Just a couple of points that I just want to add. I think one of the most important things that we need to understand is the metabolic alterations that happen in a patient who is in the intensive care unit, especially patients who have background sepsis, septic shock, traumatic brain injury, acute pancreatitis, severe burns, where there is a significant inflammatory response. We need to understand that there is a significant activation of your hypothalamic pituitary axis. There is an activation of your neurosympathetic system, which leads to severe catabolism. And this catabolism leads to significant loss of your lean body mass. Now, there is nothing that we can do to kind of reverse this catabolism. Our aim should be try and see if we can minimize the damage that happens because of this. And the only way that this damage can be minimized is by early, appropriate nutrition. Now, the question of when to start, there's never been a doubt. Almost all the guidelines recommend that you start nutrition in the first 24 to 48 hours. Of course, after you have achieved your primary resuscitation targets. But how to go about once you initiate has always been a question of debate. Now, there are multiple trials which have looked at providing full nutritional prescription in terms of both calories and proteins. Majority of the trials where they delivered complete nutritional prescription was associated with poor outcomes. Now, the probable mechanisms could be either overfeeding or inhibition of autophagy or refeeding syndrome. Are there other mechanisms which can contribute to the increase or poor outcomes in these patients? We are still not very sure. Hopefully, just like in other aspects of intensive care, maybe we can have some biomarkers which can help us understand or identify those patients who are, probably be at risk or harm with complete nutritional delivery. Now, what is very clear is start slowly. Don't rely on any of the formulas because they tend to either overestimate or underestimate. If you have an index telemetry, use it. If not, go with whatever the conventional guidelines recommend. But definitely go slow on both the calories and the protein, because even early high protein intake in the critically ill patients have been shown to be associated with poor outcomes, as has been shown in the latest France study. Is shock a contraindication? No. I mean, we have good data to suggest that even in patients who are having hemodynamic instability or on vasopressors, you can start a small amount of feed, provided you are able to achieve and maintain a stable mean arterial pressure consistently, or your vasopressor requirements are not going up. But in these patients, be very careful to monitor your enteral feeding tolerance, because there is a high probability that these patients may land up with intolerance of feed. So just keep a watch on your GRVs in these subset of patients, your lactates, your glycemic control. Should we monitor GRVs regularly? No. Again, there is no data, and most of the guidelines have now given up the idea that routine GRV monitoring is needed. Keep a watch, because majority of the critically ill patients, if they are not able to achieve their prescribed volume of enteral feeds, then there is a high probability that these patients may land up with severe micronutrient and trace element deficiencies. And in this subset of patients, you may have to supplement additionally your micronutrients and trace elements. Refeeding syndrome is a realistic possibility. Majority of the times we look at only the cardiovascular aspects, but refeeding syndrome can affect practically every system, including your neurological system, cardiovascular system, your respiratory system, renal system. So Any patient where you find a more than 30% drop in your phosphate has an unexplained neurological deterioration, keep in mind the possibility of a refeeding syndrome. And in these patients, ideally give your thiamine at least 200 to 300 milligrams per day, at least half an hour before you initiate the feeds. Parenteral nutrition, as was believed for a long time, it is not harmful. Most of the effects of parenteral nutrition happen because of inadequate handling of the lines or the way the parenteral nutrition is delivered. Otherwise, per se, it does not have been, it has not been shown to be more harmful or bad as compared to enteral nutrition. Wherever it is needed or wherever it is indicated, wherever patients are unable to be fed enterally, I think parenteral nutrition should be considered very, very strongly. So, thank you. Those were a few of the things that I just wanted to add upon.
Thank you, Ghanshyam. Thank you, Khalid. Again, as usual, a very comprehensive review of nutrition and nutritional practices and strategies in the ICU. But I don't agree with the first statement made by Khalid that it is very neglected and you ignored part of intensive care currently. Maybe 10 years ago, 15 years ago, it was part of it was the attitude, but now I think it is become part of prescription. Nutrition is part of prescription. Just like you look at culture reports, you look at hemodynamic parameters, you look at ABGs while while giving antibiotics or setting the ventilator or adjusting the vasopressors or deciding on RRT. There are several parameters which you look at when you chart nutrition for the patient. How to start, when to escalate, when to de-escalate, what to give, what not to give. Some kind of a stewardship for nutrition has come into ICU practice big time in the last 10 years. So I think that the paradigm has shifted. Nevertheless, it's a good, our own data, Ghanshyam said about feeding in shock, so I thought I'd share our own data. Dr. Arun Kumar, one of the DRNB trainees in my former institute, who started his thesis when I was there, actually has completed his work on feeding in shock. And we have found that hypocaloric initiation of hypocaloric feeding, even when patients with moderate dose of vasopressors, actually results in better outcomes for this patient. The survival is actually better. We are going to publish this or present this very soon, but it's an ongoing study. I think we've got some more patients to um, analyze. So it is a good data, but it's a very interesting and very encouraging, probably innovative publication. One of the things which is very closely related to nutrition is glycemic control. And next week, we will talk about glycemic control in the ICU. That will be done by Dr. Ashutosh Kumar from Faridabad. Please do join us again next week. I hope all of you welcome the 2024. And we hope this current calendar year is going to be prosperous, successful, and bright for all of you. Please do join us next week for glycemic control in the ICU. If you have any concerns, queries, comments on the topic discussed today, please post them on the group from which you got the link to join this program. And the moderators or the speaker will try, or both will try to answer this question. Thank you very much. Have a good day.
Shinal, before we end, we are very happy to announce the date for the 9th edition of Hyderabad Intensive Care Symposium, but it's 10th to 12th May. We will roll out the registration process shortly. Request all of you to kindly register early for the 9th edition of Hyderabad Intensive Care Symposium.
Thank you very much. Have a good day.
Thank you.